lymphadenopathy. First, we will just first define lymphadenopathy. Okay. So for the brief overview, we will discuss this introduction, etiology, history, and physical examination. So for the introduction, so let's first discuss a brief background on anatomy. So lymphatic system is in the peripheral circulation. We have both arterial and venous. So the lymphatic system is an extensive network that drains. They drain the fluid called lymph from the body tissues and returns it to the circulation. So brief anatomy, the right lymphatic duct drains right the right side of the head, just like what you see in the picture. Can you see my pointer? Not, no. So the violet shaded part of the body is the right, this the one that drains to the right lymphatic duct. So this include the right side of the head, neck, thorax, the right upper limb, and they both empties to the junction of the right internal jugular and right subclavian veins. This one. The thoracic duct, which is the rest, they collect lymph fluid from the rest of the body. So majority of the lymph fluids, including the left side of the body, it collects to the thoracic duct. So that's the brief anatomy. So what is a lymph node? So lymph node is a part of the lymphatic system. So normally, they're not palpated. So cells within the lymph nodes engulf the cellular debris or bacteria. That's the time that you will palpate the lymph nodes. So the most common group you are palpating in the physical examination are in the neck, axillary, down to the femoral lymph nodes. So quiz time. No, I'm just joking. So lymphadenopathy is an abnormal increase in size or altered consistency of the lymph nodes. So they are the abnormal enlargement of one or more lymph nodes since nodes are grouped together. So this could be a manifestation of a regional disease or a systemic disease. So for example, if there is pain in the axillary lymph nodes, this could indicate the problem in the hands or the breast of the same side. So if it's in the inguinal area, it will indicate the problems in the lower extremities. If it's in the cervical area, it will indicate problems in the scalp and the head. So finding of the enlarged regional lymph nodes should lead to a careful examination of the drainage area. So that's how we check or we know where's the source of infection. So you should know that regional lymph nodes drain specific areas. So for the key terms, what is lymphadenopathy? So lymphadenopathy is an abnormal enlargement of one or more lymph nodes, usually more than 1 centimeter in adults. In generalized lymphadenopathy, by the word generalized, so it affects multiple body regions. And localized, of course, it will affect a single body region, like leg, cervical, or inguinal. So generalized lymphadenopathy is more often due to systemic infection, immunological abnormality, and malignant change. So generality results from infiltration of lymph nodes by inflammatory or neoplastic cells, or the proliferation of resident lymphocytes and expansion due to hemorrhage or abscess formation. So let's go to etiology. So these are the common etiologies of lymphadenopathy. The most common one is infectious, like bacterial, such as the following: viral. For example, in German measles, cervical lymphadenopathy will differentiate from plain measles. So, how? In patient rashes, always check for cervical lympadenopathy. In German measles, there's a cervical lympadenopathy compared to plain measles. That's the difference. So, other sources of lymphadenopathy like TB, leprosy, and scabies. So, another source of lymphadenopathy, immunology. So, another uh, common etiology of lymphadenopathy is hematologic, which is the most common one are leukemias and lymphoma. So for Hodgkin lymphoma, acute and chronic TB, myeloid, and cytoid. So the one you will focus here is always for leukemia or lymphoma, which are malignant. So we can also for malignancy, metastatic tumors to the lymph nodes. The primary are in the then the lymph nodes will be a sign of a metastasis if they are palpated. So another example, another cause different diseases, lipid storage diseases, allergic like serum sickness, vascular like Kawasaki in children, traumatic like in serum sickness associated allergic reactions. So for the miscellaneous, okay, but for for
Excuse me, dog.
yes,
Dog, your audio is not clear, dog, because it was offing in between and again it was coming. The audio is stopping and it was starting again, dog. Now also we can't hear your audio. No, dog. We can't hear your audio, dog. Now also.
right now.
Right
But
now I can hear
but
you.
my
Again it gone. It was not. We can't hear.
but now.
Dog, once again.
Can you hear me now?
Yes, yes, dog. Now we can hear you.
Okay.
Okay,
So
dog.
you didn't hear me from the start. You can hear me naman.
Yes, dog.
You just interrupt me if you can't hear me. Okay? Thank you for that.
Okay, dog.
Uh, so toxic drugs can also induce lymphadenopathy. So these are the most important ones in our topic, history taking. So history taking will give you 80% of the correct diagnosis. So history taking, we should establish the onset and the course of lymph node enlargement. Number two, we will determine the absence or presence of other symptoms. Number three, we will determine if it's localized or generalized. And you also should ask about the occupation. So for the systemic manifestations, this includes fever, weight loss, itching, then the most important symptoms of malignant lymphoma, So history of cancer with lymph node enlargement will lead you to a metastatic disease. For example, if the patient had travel history, maybe the cause is infectious. And if the patient drinks alcohol or used tobacco smoke, usually it will lead to head and neck cancer, even liver and GI cancer. So another the thing you will ask the patient is there any recent febrile illness or contact with pets? So for example, toxoplasmosis from the excrement of cat. And we should also ask about the exposures related to work, home, hobbies, travel, medications, and even sexual history.
Yes, ma'am.
Yes? Okay. So these are the examples of an open-ended questions that you will ask to your patients. So where do you feel it? So location. What does it feel? Because lymphadenopathies differ from nodules. When did you first notice it? The duration also. Does it seem to be changing with time? So we can determine if it will be malignant or not. So have you had any recent illness or other symptoms? So such as that. And other questions, what are the relieving factors? What makes it better? What makes it worse? Or what are the precipitating factors? What brings it on? So, and other associated symptoms. And also in the past medical history, we will ask if the patient had anything like the one she's complaining before, right now. If she already experienced the same symptoms. So that's the basic history of lymphadenopathy. So what will we do? Siyempre, 80% will be coming from the history and 20% will give you correct diagnosis coming from the physical examination. So these are the clues. So very thorough examination of all regional lymph node and evaluation for hepatosplenomegaly. So for example, in lymph node, we should note the size, the location, and the consistency. So we'll note if it's soft, hard, matted together, or stony hard, or rubbery. So why? Because usually if the lymph node is hard, stony hard, most likely it is malignant. So for basic physical examination, specific lymph nodes drains specific part of the body. So for example, preauricular lymph nodes are the one you can see on the anterior part of the ear. So usually the preauricular lymph nodes drains the scalp and the skin of the face. So you can develop differential diagnosis using that because maybe the patient had or has scalp infection or tuberculosis or mycobacterial infection. For malignancy, they could have lymphoma or head and neck squamous cell carcinomas. For example, another one is submandibular lymph node. If you can feel a submandibular node, just like what you see in the figure, so usually submandibular lymph nodes will be palpated if you have infection on the oral cavity. So for example, upper respiratory tract infection, mononucleosis, dental diseases, those are the usual examples. And if the lymph node you will palpate are the anterior cervical nodes, just like here. So usually, the culprit may be from the larynx, the tongue, or pharynx or the anterior neck. So it's regional. So depending on the lymph nodes that you palpate, you will deduce from there the part of the body that may be the source of the lymphadenopathy. So here, for example, axillary lymph nodes. Usually you can palpate the lymph node on the axillary when you have a breast mass or mastitis, inflammation of the breast, or any infection of the upper extremity and the anterior thoracic wall. So in infraclavicular lymph nodes or below the clavicle, if you can palpate a lymph node there, it is highly suspicious of a non-Hodgkin's lymphoma. So when the lymph node you will palpate is in the inguinal part, we will check or you will differentiate if it's sexually transmitted disease or just a skin infection. Or it could also be malignancy, like squamous cell carcinoma of penis vulvarianus or Kaposi sarcoma. So number two, first we determine the consistency. Now, let's check if it's movable. So fixed or movable. So determines if you're dealing with malignant enlargement and involvement. So usually if it's fixed, most likely it's malignant. So these are the common questions, and the other part of the column is the one that you will think about if you will ask the question, did the patient have history of cancer? Maybe the patient has metastatic cancer. Just maybe. It's just a probability. It's not absolute. So if the patient had family history of head and neck cancer, most likely the patient has multiple endocrine neoplasia. If the patient has ever been exposed to radiation, maybe it's cancer. So if the patient had positive TB skin test or the PPD, so you will think about tuberculosis. If the patient engaged in unprotected sexual intercourse, maybe it's HIV or human immunodeficiency virus. So if ever you will ask the patient if the patient had injection of drugs, maybe the patient had HIV, hepatitis B and C, or syphilis. If you will ask the patient, does he experience a fever, joint pain, rash with recent medication use? Maybe it's medication-associated serum sickness with lymphadenopathy. If the patient has a mole that has changed in pigmentation, size, or shape, maybe the patient has melanoma. So there's a lot of clues depending on the history and physical examination. So another example is, do you have a painful blistering rash in a band-like distribution on one side of your body? Maybe the patient has herpes zoster. In herpes zoster, usually you will feel pain first before the rash appears. So that's the difference of the chickenpox and herpes zoster. And for the quality, is the swollen gland painful or tender? So maybe it's infectious. So if it's tender. So if it's hard, the consistency metastatic. If it's draining, bacterial or mycobacterial infection. With regards to the time course, if it's been present for over a month, maybe it's malignancy. Most likely, not maybe, most likely it's malignancy. If the size continuously increase, it's malignant. So associated symptoms, in addition to the lymph gland swelling, you have also to ask for any fever, chills, sweats, because maybe it will be a generalized lymphadenopathy because it's due to infection. So, and etc. There's a lot. Uh, Unintentional weight loss, malignancy, HIV, tuberculosis. If the patient has pain or nodule in a testicle, it's testicular cancer or mumps. If there's a blood in urine and you felt lymphadenopathy in the inguinal area, maybe it's prostate cancer. So actually, that's just brief because lymphadenopathy is general. So in short, you will never palpate a lymph node if your patient is not having any infection or any sickness. So normally, lymph nodes are non-palpable. If it's palpable, you will think of an etiology, or you will think of a disease or illness. And lymph nodes drain specific regions of the body. When you know the specific regions of the body, for example, the one I told you a while ago, if it's in axilla, usually breast and upper extremity. So you will not think of a differential diagnosis of testicular cancer if the one you palpated is in the axillary region because the because of the location. From that you can deduce your impression or your diagnosis based on the location of the lymph nodes. So, any questions about lymphadenopathy? Any questions?
No, doctor.
No. Uh, Clear naman. Is it clear?
Yes, doctor.
Actually, the main gist of the topic is that lymph nodes is not palpable normally. That's the main message. And lymph nodes will let you will have you will give you a clue. I mean, so the location of the lymph node will give you a clue where is the infection going, where is the disease located, or where's the problem of the patient. So lymph nodes are regional. That's the main message of the lecture. So next we will go to the more um more broad topic, which is hirsutism and virilization. So let's proceed to the second topic. So approach to hirsutism and virilization. So usually you can this manifestation or symptoms or signs and symptoms is not commonly encountered in an outpatient department. So we will just go through this topic briefly. So hirsutism. So what is hirsutism? So basically, it's excessive male pattern hair growth in a female. So as you can see in the figure, the illustration, this facial hair is usually not seen in a female patient. So usually, this is for males. So if you see a patient with excessive hair growth in a excessive male pattern hair growth in a female, that's hirsutism. That's the basic definition. So the hirsutism may be accompanied by cutaneous manifestations, so such as acne, male pattern hair loss, or the one we call androgenic alopecia. So this could be due to androgen excess, or the epidermis are sensitive to androgen stimulation. For example, acne, because of the activation of sebaceous glands. So hirsutism acquire both male pattern hair growth and hair loss. So not only hair growth but also hair loss in males. You will see them in females. So what are the characteristics? So usually they have thick axillary hair. They have hair along the linea alba, which is the one uh aligned to the, what's that? The navel, umbilicus. That's the linea alba. So periareolar hair. So usually males has hair on their areola, but not typically in a female. So that's hirsutism. Even pubic hair distribution. Normally, the female has inverted triangle pattern, but they have a distribution just like in males, which is diamond shape. So the hair is usually excessive amount. There's an excessive amount of terminal hair. What's terminal hair? It is coarse, mature, and highly pigmented hair in areas not normally for a female. So other characteristics, hirsutism is not an increase. Take note of this one. Maybe it will appear in your exam. So not hirsutism is not an increase in the number of hair follicles, but an alteration in their character. So it's in the character of the hair, not the quantity of the number, not the increase in the number of hair follicles, but it's the quality. So increase in transformation of the vellus hair, usually vellus hair meaning fine lightly pigmented, to terminal hair, the coarse one, and darkly pigmented. So versus hirsutism is not the same as hypertrichosis. What is hypertrichosis? So hypertrichosis is the appearance of excessive amount of terminal hair in areas normal for a female. And number two, it's alteration in character of hair follicle from vellus to terminal hair. So as you can see in the picture, you can see the skin of the face already. It's already covered with excessive amount of terminal hair. So this is hypertrichosis. So what are the consequences of several, hirsutism is a consequence of several factors. So this is the pathophysiology of hirsutism. So why is there hirsutism? Because of the increase in androgen production. That's the number one. Number two, there's an increase in the sensitivity of androgen receptors at the level of the hair follicle. And third, there's an increase in the activity of the 5-alpha reductase, which is an enzyme that converts the inactive form of androgen into active form. So there's hyperactivity of the 5-alpha reductase, or the rate limiting that will convert the androgen to its active form. So those are the three main factors that will lead the patient to have hirsutism. So this is an example of a scoring system called Ferman-Galway scoring. So we'll not delve into that, but I would just want you to know that there's such scoring of hirsutism, named as Ferman-Galway. So the interpretation of the scoring is usually if it's less than 8, it's normal. And if it's more than 8, meaning there's an excess androgen-mediated hair growth. So the patient should undergo further assessment and evaluation. So normally we have three types of hair. So we have the lanugo, which is the fetal hair, the vellus, which is the short, fine, unpigmented. Usually it's before puberty, and terminal hair, which are long, coarse, pigmented, arises from the vellus hair. So usually it's the cycle, vellus to terminal hair. So we already talked about that, terminal hair. So these are the cycle of growth of hair. So we have 4 cycles. We have the early anagen or the early growth. We have the anagen or the active growth. We have the catagen or regression. We have the telogen, which is the resting or stable phase. So why am I telling you this cycle growth of hair? Because in hirsute women, the stage that is prolonged and exaggerated is the anagen phase. So that's why I discussed the cycle. So the stage that is prolonged and exaggerated in hirsute women is the anagen phase. That is why the vellus hair becomes terminal, with an exaggerated length, size, and color. So androgens lengthen the anagen phase. And this will result to an increase in the hair follicle, the diameter, and also increase in sebum production. In hirsutism, anagen phase is prolonged. That's what I told you a while ago. But in androgen alopecia, anagen phase is shortened. Catagen and telogen phase is prolonged, resulting to hair loss. So that's why there's the difference of androgen alopecia and hirsutism. The phase of androgen alopecia, the prolonged one is the telogen phase and catagen phase. In hirsutism, anagen phase is prolonged. So this is the normal route or illustration of an androgen production. So in androgen production, 90% of came the 25% of testosterone came from adrenals and ovary. 10% of uh, the the production of DHEA is coming from ovary, and 90% comes from adrenal gland. So in short, androgen production is both adrenal and ovary, but majority it's in adrenal gland. So what are the sources of androgen? So that's what I told a while ago. Both male and females, adrenals. In male, testes to a greater extent. In female, ovary to a lesser extent. So what is androgen sensitivity? So, for example, eyebrows and eyelashes, they are insensitive and growth is independent of androgen. For pubic area and axillary, they are sensitive to even low levels of androgen. And for facial, chest, upper abdomen, and back area, they require greater level of androgen. So for example, in the scalp, hair loss because of androgen cause hair to spend less time in the anagen phase. Anagen is about growth. So less time in the anagen, that will lead to hair loss. So anagen phase shortens, causing male pattern baldness. That's what we call temporal balding pattern here. So another illustration of the androgen synthesis. So it came from pituitary, adrenal, and even ovaries. So in pituitary gland, the one responsible for the androgen is the which is the zona reticulosa. And also the what's this? Zona fasciculata of the adrenal cortex. So both fasciculata and reticulata is responsible for the androgen. So it's under the pituitary gland. So under adrenals, we have the theca cells, which produce the androstenedione and testosterone. For the ovaries, the granulosa cells, which converts estrone and estradiol. So that is the part of hirsutism. So basically, hirsutism, in a female patient, you can observe male pattern of hair. Not only male pattern of hair growth, but also male pattern of baldness. So in virilization, there is a difference of virilization and hirsutism. So in virilization, it's a condition in which androgen levels are sufficiently high to cause hirsutism, plus there's an additional, so hirsutism plus additional signs and symptoms that is virilization. That's the difference. So what are these signs and symptoms? Usually it's the deepening of voice, breast atrophy, increased muscle bulk, clitoromegaly, increased libido because testosterone is libidogenic. So these are the common additional symptoms or signs in virilization. So virilization is a more severe condition that requires further evaluation. So from the root word viril, adjective meaning masculinity. So an ominous sign suggesting an ovarian or adrenal neoplasm or tumor. So if you will see a patient with virilization, it's a sign of ovarian or adrenal tumor or malignancy. So hirsutism and virilization are closely linked. Hirsutism could be the first manifestation, then ultimately it will lead to virilization if left untreated. So hirsutism could lead to virilization. So what are the causes of hirsutism? So these are the common causes: adrenal disorders, ovarian disorders, drug-induced, especially if the patient is a bodybuilder, they abuse testosterone. So also miscellaneous causes. We will not tackle on that. So under adrenal disorders, so the first one is the congenital adrenal hyperplasia. It's a disorder where there is an enzyme that is defective or absent. What's the most common? There are three enzymes, but the most common deficient in this disorder is the 21 hydroxylase deficiency. Although there's also 11 beta hydroxylase, there's also 3 beta hydroxysteroid dehydrogenase. But the most common one is 21 hydroxylase deficiency. So this is the example biochemistry part of how the testosterone developed. So it's from the androstenedione under the progesterone level. So if there's an increase in ACTH due to decrease in cortisol, due to the decrease in cortisol, it will aggravate the cycle, making the female more viril, right? So it's more on the cortisol. So increase in ACTH or the cortisol due to decrease in the diba? It's like a negative feedback. So let's go back so that you can imagine. Where is that? So here, so ACTH is from the pituitary gland, right? So basic biochem. So ACTH is from the pituitary gland. So if there's a decrease in the cortisol, this will signal a negative feedback to the pituitary to increase the ACTH production. So you remember the biochemistry? So that's the reason here in congenital adrenal hyperplasia, there's a decrease in cortisol. That's why it will aggravate the pituitary gland to increase the ACTH, making the female now more viril. So here, the treatment here is cortisol. Why? Because the culprit is there's a decrease in cortisol. So how do we treat a decrease in cortisol? We give cortisol or steroids so that it will exert the negative feedback to slow down the pathway. So without cortisol, there's no negative feedback. So there will be an excess ACTH production continuously that will stimulate the adrenal cortex, leading to hyperplasia. That's why we will see them as ambiguous genitalia. Because there's no negative feedback. So in 21 hydroxylase deficiency, there are actually 3 primary forms. So the three primary forms here is the simple virilizing form, which is the classical form, salt wasting form, and the non-classical form. You will not call that. It's already uh, deep topics. So let's just check the simple virilizing form, which is the classical form. The classical form is due to an excess in prenatal production of androgen. So that's why we see at birth there are patients or there are infants that you can see they have ambiguous genitalia. So usually we have masculinization of the female genitalia. So males with this disorder appear normal at birth. Of course, it's not that evident. But linear growth is accelerated initially, but eventually will have short stature. So, meaning these patients have short stature uh, because sex hormones cause early epiphyseal fusion. So why do they have short stature? So because of the hyper functioning of the sex hormone, it will lead to the fusion. What's epiphyseal? So usually that's the the reason why we have growth. So in a bone, if you can remember the anatomy, so epiphysis, metaphysis, right? In between, and at the distal part and the proximal part are the epiphyseal, where you can locate the epiphyseal plate. So that's where growth comes from. So because of the excess sex hormone, the epiphyseal plate will in prematurely closed. So eventually the patient will have a short stature. So these are the adrenals, congenital adrenal deficiency. The adrenals produce three hormones. So these are the three groups of symptoms. We have the cortisol deficiency, we have the aldosterone deficiency, and androgen excess. So you will tackle this one when you go to medicine proper. So they will tackle about the endocrine part, in the endocrine part of medicine. So next example is Cushing syndrome. So this is common. This you will see patients with Cushing syndrome in the outpatient department. So what's your clue for a Cushing syndrome? Number one, moon fuzzy. So they're like this. And buffalo hump, you can see at the back. Abdominal striae, usually more than 1 centimeter. They have truncal obesity, but they have thin extremities, plus hirsutism. It's because of the excess cortisol. So, another one is adrenal carcinoma. So, the most common one is the adrenal cancer, which is malignant, but it's rare. So, there is a slight female predominance, and majority are sporadic or unilateral. So, the most common hormone secreted by the tumor is what? In adrenal carcinoma, the most common hormone secreted by the tumor is cortisol. That's why the patient you will observe the patient to have Cushingoid features. The one I told you about a while ago, buffalo hump, moon fuzzy, domestic, truncal obesity, like that. If it is an androgen secreting tumor, virilization would be the main manifestation. And under ovarian disorder, so there are androgen secreting ovarian tumors. So ovarian tumors like granulosa theca cell tumor, areноblastoma, this germinoma, those are the example of ovarian tumor. Under adrenal tumors, we have the adrenal cancer and adrenal adenoma. In ACTH secreting tumors, we have, these are rare. They have the sex cord tumors. So, this may manifest with hirsutism, virilization, and abdominal mass. So, if you see a patient with abdominal mass plus hirsutism plus gynecologic problems such as amenorrhea, so usually this patient, they develop an androgen secreting tumor. So, you will, that's the clue to tell you that the patient is having or has an androgen secreting tumor. They have an abrupt onset of symptoms and a more rapid progression of signs and symptoms compared to PCOS or the polycystic ovarian syndrome. So signs of virilization such as clitoromegaly, frontal balding, deepening of voice are common, which indicate a very high testosterone level. Usually the high testosterone level is 2.5 times the upper normal. So this one, the more common one, PCOS. So polycystic ovarian syndrome or PCOS. So what is this polycystic ovarian syndrome? So this is PCOS is the most common cause of hirsutism. Remember that. So PCOS is the most common cause of hirsutism and the most common endocrinopathy in the reproductive age group. So what is PCOS? It's basically amenorrhea plus hirsutism. So testosterone levels are virtually greater than 200 nanogram per deciliter. So that's the testosterone level of PCOS. So in the Asian population, it is around 10 to 15%. So what is the criteria for PCOS in adults? So we have the 2003 Rotterdam criteria for PCOS. So 2 out of 3 criteria. So number 1 criteria or the first criteria is the androgen excess. We have the clinical signs of hirsutism or biochemical, the assay, the testosterone assay. Number 2, if you have the ovulatory dysfunction. For example, you have oligo, meaning minimal menstruation, anovulation. This will be the clue that the patient has amenorrhea or a very irregular period. So that's a clue that the patient is having ovulatory dysfunction. And last but not the least is the patient having polycystic ovaries by ultrasound. So how is this? So at least one ovary with 12 follicles. The size of the follicle should be 2 to 9 nanometer or the volume of 10 ml. So that's the criteria for the ultrasound. So what are the features of PCOS? So, and features of PCOS, number 1, of course, menstrual abnormality, which is present in 80% of patients. So, infertility or anovulation, number 2. Number 3, hirsutism in 60%. So, not all will manifest with hirsutism. Acne in 70% and alopecia. So, that's the clinical features of PCOS. So, in PCOS, you have an increased risk of diabetes, increased risk of atherosclerosis and cardiovascular events. So, in increased risk of diabetes in patients with hyperinsulinemia, because why? Why? Why do they tell you that you will have an increased risk of diabetes? Because PCOS is a pre-diabetic state. Because the main lesion in PCOS is insulin resistance, which is responsible for the type 2 diabetes. So remember that. So we have also pregnancy related. So it is rare and less common. Usually, there's a hyperreaction of luteinase of pregnancy, which is the transient increase in androgen level. But eventually, it will go back to normal once the baby is delivered already. So, uh, third one is drug-induced. So we have hormonal drugs that could induce PCOS. So we have the anabolic steroid, which is commonly abused. Usually, they use the equine testosterone. The equine testosterone is from the horse, right? So, for example, another example is danazol, which is an anti-estrogen drug, OCPs with androgenic progestins, and ACTH. Glucocorticoids. So, glucocorticoids are the most commonly used by asthmatic patients. So, if the patient is already a chronic use of steroid, you can uh, you can see the Cushingoid features of those taking uh, steroid as a reliever or a maintenance in their asthma. So, excess cortisol caused by glucocorticoids will be shunted towards androgen. That's why. So, the excess cortisol from the glucocorticoids, the pathway will be shunted towards androgen production. That's why they have the virilization. Under anabolic and androgenic steroids, anabolic by that term, it enhances, build, growth. So anabolic enhances tissue development. Androgenic, it produces masculine characteristics. That's the difference. So what are the side effects? So number one, in female, there will be an increase in body hair, particularly in the face. Change in facial feature, deepening of voice. The deepening of voice in virilization is what? Permanent. It's not reversible. It is permanent, the deepening of voice. There will also be a change in breast size and but not the least, infertility. So what are the non-hormonal drugs causing hirsutism? So these are the drugs that will commonly cause true hirsutism versus hypertrichosis. So true hirsutism usually is steroids. Hypertrichosis na minoxidil. Diba? And there are also miscellaneous causes. So such as the following. I will not tackle on that na. So idiopathic hirsutism. So idiopathic hirsutism is an excess in terminal hair production in androgen dependent areas. Where are the androgen dependent areas? So it is to rule out PCOS already. So if there is such, we should rule out the PCOS because usually that's normal androgen level. That's why it's drug induced. So this drug induced hirsutism is the second most common cause of hirsutism after PCOS. So the first common cause of hirsutism is PCOS. The second one is the drug-induced. This drug-induced hirsutism occurs in 50%. So that's the common etiologies of hirsutism and virilization. So the one you will master is the data gathering. So how do you get that proper information in order for you to properly check or assess the patient? So of course, history. In history, take note the onset and duration of virilization. If it's rapid progression, most likely it's malignant. And under menstrual history, if you if the patient has amenorrhea plus hirsutism, what will you rule out first? So first, you will rule out pregnancy. Then consider PCOS or tumor. So do not jump to PCOS already or tumor. Amenorrhea and hirsutism, can be observed is commonly observed in pregnant patients. So family history, hair patterns are similar in families. So you will ask the patient if the patient has any of the family members with hirsutism. So another important history is the drug intake. So usually herbal supplements contain steroids. So that's the history part. So let's go to the physical examination. In physical examination, these are the common one. So you will check the hair pattern. Instead of inverted triangle, it's triamond shape. Balding, male pattern baldness. The body habitus, maybe the patient has Cushingoid features, buffalo hump, Monfasi, truncal obesity. Female contour. So no, there's no female contour already. Atrophic breast changes. So there's no breast in short. Atrophic. There's atrophy. And clitoromegaly. So we're in a few where we will finish in a while. So we have 5 slides left. So another cause is ovarian masses. We will check if the patient has Cushingoid feature. Also na acanthosis nigricans. You know the acanthosis nigricans? It's the hyperpigmentation of the nape area. There's hyperpigmentation. So usually, if the patient has those, usually it's associated with PCOS. Or yeah, this one, the dark pigmentation in the neck. Eventually, patients with PCOS will become insulin resistant. So they will eventually become diabetic if it's not properly assessed or properly managed. Generally, these are the common causes of virilization. So thyroid disease, Cushing syndrome, virilization, acanthosis nigricans. Generally, we have the hirsutism and virilization. So in the breast, you will check that the patient has galactorrhea. So what's galactorrhea? It's the hyperprolactinemia accompanied by the increased adrenal androgen. So usually, uh, the female will produce milk. You normally when the patient is pregnant or in there she's lactating. So in galactorrhea, there's hyperprolactinemia, excess prolactin production, which is accompanied also by adrenal androgen. So that you will also assess that one. In pelvic naman, in pelvic you will check for any mass. So maybe the patient has hypogastric mass, inguinal mass, maybe it will pertain to a tumor. Is it malignant or benign? So most likely, in a patient with virilization, the patient plus a mass palpated, most likely it's malignant. So that's all. That's actually the end of the topic. So any questions or any clarification? So I'll just take a picture of the